Our second speaker for this session will be Dr. Nicholas Pronk. Dr. Pronk is the Vice President for Health Management and Chief Science Officer for HealthPartners, an integrated health management health system headquartered in Minnesota. He is also a senior research investigator at the HealthPartners Institute for Education and Research and an adjunct professor of social and behavioral sciences at the Harvard School of Public Health. Dr. Pronk's work connects evidence of effectiveness with the practical application of programs, services, and policies that measurably improve population health. Dr. Pronk, please. Thank you. Okay.
Good morning, and thank you very much for the invitation to be here this morning with you and talk a little bit about frameworks. So my focus is really to sort of highlight some frameworks in that connect the notion of knowing what baselines in obesity, for example, are to what was happening in the field in terms of changing those baselines. So connecting knowing to doing. So in doing that, I'd like to first put the frameworks in a little bit of context and then present three different ones to you. The first one related to the Evaluating Progress in Obesity Prevention, the EPOP report. The second one that is explicitly set up to connect practice and research. And then the third one that is very much driven by practice situation, addressing plausibility and practice reality. Connect the dots towards the end and then make some concluding statements. This quote from Goethe, the knowing is not enough, we must apply, willing is not enough, we must do. Very familiar to the Institute of Medicine, as most books and reports from the Institute start with this quote. But I think it's particularly relevant to this, to today's topic, in that we do want to know how, whether what we did actually reduced obesity. We do want to know if the change that we see is real, and given the interventions that were implemented, are the changes observed plausible? And for that, any framework that can use a feed-forward and a feedback mechanism at the same time can be useful. So the EPOP report that came out of the Institute of Medicine in 2013 actually presents a framework like this. It provides a set of inputs, activities, outputs, outcomes, and intended impacts and improvements in a feed-forward and a feedback framework. It then goes on and also applies this to a system context, recognizing that obesity is a highly complex topic, and in fact systems approaches are very appropriate for this. In here, the framework is really applied to a background that provides networks and feedback loops towards individuals, families, peers, communities, regions, states, and all the way up to the nation. The second framework is designed to really explicitly connect practice and research. So it starts with an efficacy and effectiveness research context, applies it to practical applications, which then allows you to implement a research-informed practice approach. It then applies evaluation, action research, participatory research in the practical context, driving towards new hypotheses that really then provides practice-informed research. The model looks like this. If you start from a research perspective, starting with efficacy research and effectiveness research, and create from that systematic reviews that allow you to observe what is going on and what do you know about a given situation. Summarize that research, reflect on it, sense it, work towards solutions that can be applied in the practice situation, draft new solutions, prototype them, pilot them, and standardize them. For that, you can add tools such as RE-AIM, which really is a framework in and of itself that came out of an evaluation context to identify factors that are tied to generalizability of research, as well as the 4 S's and the PIPE impact metric, which we'll talk about here in a minute, which are more coming out of the practice situation and are particularly interested in applying business and marketing and market context to solutions. And of course, that then presents this research-informed practice path. On the practice side, once implementation of a standardized solution ends up happening, you apply evaluation using continuous quality improvement, total quality management, Six Sigma, Lean, PDSA cycles, as well as action research spirals and participatory research approaches to drive towards new hypotheses that can be informative to research. This then provides a practice-informed research path. Of particular interest is this translation curve, which is an adaptation of Klaus Otto Scharmer's work from MIT, which really identifies a process that is nonlinear to make sure that what we observe and what we know can be translated into a practical application. So to focus in on this particular translation curve, observing is really that first step, which is really based on seeing, if you will, reality with new eyes. Waiting to make decisions or judgments about what you see until you summarize it, where, for example, systematic reviews can be very informative, and apply it with a context of understanding prevalence, understanding incidence, understanding trends, and what is driving those. Reflecting really relates to the idea of contemplating and uncovering what's the meaning of all of this. Putting it back in context so that you can identify what a new solution may start to look like. Sensing is when all of that thought process starts to give rise to some ideas of new solutions. And presencing is the spot where really the idea comes to light. So the idea meaning, the presencing meaning, bringing literally the future into the present. Drafting is the first iteration of a solution that you can actually touch and feel. Prototyping is building it so that you can test it with a small group and improve upon it. Piloting is to place it in the market context where the market is sort of the real world setting. And you can test it out before you go full scale with a standardized solution. The third framework, which is really embedded in the practice and research connected model, is really set up to address plausibility. The question here is the observed incidence, prevalence, and trend reasonable based on what we know what was implemented? Here there is an explicit connection between how you create your solutions in terms of design with the measurement framework that tests whether or not things are changing. So here the key metrics or the key factors or elements associated with design include effect size. So as you translate from research, most of the time as you translate you lose effect size. You got to make sure, though, when you go into the marketplace or into the field, that you have enough effect size to still be effective. So effect size is certainly a key design principle. Secondly, scope of services. Scope of services is important because without it, you cannot understand how much things cost. You need to be able to get a good handle on what you're providing. So costing and pricing are actually very important. And scope of services can allow you to understand that. Scalability is really making sure that the solution you implement is at the end of the day reaching all people that are representative of your intended audience. And sustainability is making sure that you can be out in the field long enough to get to your intended outcomes. Connecting that then to a measurement framework that is integrated with the design is this PIPE impact metric. And what you see here is that the two are connected, the 4 S's and PIPE are connected. So PIPE really stands for penetration, which is really related to the proportion of the target population that is reached with invitations to engage in the intervention. Implementation, did you actually do the work? Did you execute on it to the degree where it makes a difference? so the degree to which the program has been implemented according to its work plan. Participation relates to the proportion of individuals enrolled in the intervention according to design, according to the program enrollment and tracking mechanisms that you put in place. And effectiveness relates to the rate of successful participants, which means that you have to set a success criterion to understand what that rate means. Penetration and implementation really represent the dose of an intervention. In a sense, the program investment into making the intended changes. It's what you do. The response is really participation and effectiveness, which are what you get back, or the returns of the program itself. The overall pipe impact metric is actually the multiplicative result of the coefficients of each of these steps. So to give you an example, population health impact here of a worksite walking program, if the population is 10,000 employees, penetration at 98% means you have a coefficient of 0.98 for that element. Implementation, 85% of the work plan was actually executed, 0.85 is the coefficient. Participation, out of the potential that could enroll, which is 9,800, 98% of 10,000, 1,666 employees enrolled in the program, so the factor here, the coefficient is 0.17. And effectiveness, 750 employees met the success criterion of 10,000 steps per day, which is a coefficient of 0.45. The program impact then is the multiplicative product, or the product of this equation, and it ends up being 6.37%. So this kind of metric, you can start to compare different programs against one another, and also start to feed this back on the design principles, so that you very quickly can see that in this example, participation is the one that is really dragging the overall impact factor down. So what is it that affects participation in this negative way? What kind of changes do you make on the design side to bring that up? And so it gives practitioners a very quick and relatively simple method or framework to organize their work and get quick feedback on what's happening. So in terms of connecting the dots of a couple of these frameworks that I hope are useful in your work, certainly national, state, and local data need to be based on sample sizes and methodologies that make them credible and actionable. So very much of what we heard this morning. On the other hand, local community-based efforts need to be supported by available trend data to reduce resource waste. Oftentimes, when there is no trend data available, local communities tend to reinvent the wheel, which really ends up being waste of oftentimes scarce resources. Prevalence and trend data, at least in my mind, need to be complemented with incidence data. It gives you an opportunity to actually triangulate those three and increase confidence in what you see or what you find. It also can help identify groups at greatest risk, and it supports the plausibility of intervention effects. So, conclusions. Data frameworks to support obesity trends should be designed to inform action at the national, state, and local level. So in a sense, what you learn from the obesity data needs to be connected to the actions of making changes. When you make those changes, plausibility analyses are needed to provide levels of confidence that those interventions are working. And incidence data can complement prevalence and trend data. Triangulation may increase that confidence, support plausibility, and inform action steps. So I'll finish with a couple of the references used here and be open for questions.